Terrific, Fiona. Thank you so much. And we're going to move right along and welcome back to the podium Ritu Nayar, who I didn't introduce properly previously. She's with the American Board of Pathology and Northwestern University, and she'll give us the first of two parts regarding a board certification in pathology and radiology. So, thank you.
Thank you very much. Hello again, and it's my pleasure to be able to share with you some of the perspectives from the American Board of Pathology and how we interact with pathologists during their training and then when they're subsequently in practice. Okay, so I am a trustee volunteer of the American Board of Pathology, but I do need to mention that the American Board of Pathology has no official policy or position on the topic that we're discussing today. So the ABP's mission is to promote the field of pathology and the continuing competency of practicing pathologists. You see our logo here. This was revised in 2015, and now acknowledge the evolving discipline of pathology. In the forefront, you see the traditional microscope that represents cellular pathology and laboratory medicine. And in the background, the double helix denotes the evolution of the discipline in today's molecular era. So as a physician graduates through medical school and their chosen specialty and then becomes subspecialized in many cases and then goes into practice, certifying boards interact with trainees and then practicing pathologists by providing primary certification in their chosen specialty, subspecialty certification in the fellowships that they do, and then maintaining their certificate. This is something, as you all know, that is more recently added to the work that the board certification does. The residency fellowship training oversight is done by the Accreditation Council for Graduate Medical Education, and this body sets standards and monitors compliance. It does this through 28 specialty-specific review committees, and the current model of accreditation has shifted from the old time-served and compliance with minimal standards to a more real-time competency-based assessment that's now facilitated by real-time data that tracks a trainee's achievements. And these are the milestones that the ACGME rolled out some years ago. Certification oversight, the body is the American Board of Medical Specialties, whose mission is to set professional and educational standards for medical specialties and their certifying boards. There are 24 certifying member boards, and the American Board of Pathology as well as the ABR are both members of the ABMS. So the current training in pathology, the majority, as I said, of our residents do both anatomic and pathology, which is 4 years, after which they're eligible for their primary certification. Some of them may do only one or the other. We also have 11 fellowships that are certified by the American Board of Pathology, but there are numerous other subspecialty fellowships, including oncologic general pathology, such as those offered by Memorial Sloan Kettering and MD Anderson, that are general surgical oncologic fellowships, or more organ-based fellowships, such as breast, GYN, and genitourinary, etc. These do not have a certificate associated with them. Interestingly, I mentioned to you earlier that we decreased the length of pathology training from 5 to 4, but now we find that 96% of our residents do a fellowship, and in fact 46% pursue 2 or more fellowships at this point. This is data hot off of the press from a survey that came out in December of 2017. So the ABP Examinations and Certifications demonstrate to the public that a candidate practicing pathologist has the requisite knowledge, judgment, and skills in pathology or a subspecialty to practice safely, competently, and independently. On the right, you see, you get a sense of how many diplomats we provide certificates to in the primary core areas as well as subspecialty every year. Beginning in 2006, our certificates became time limited, and all primary as well as subspecialty certificates issued by the ABP are now time limited to 10 years, and they must be maintained and renewed in the maintenance of certification program. The MOC program measures the 6 core competencies that I mentioned to you earlier that are common between the ACGME, ABMS, and the Joint Commission for practicing pathologists. And it does so in a 4-part framework. The first is a demonstration of professionalism and professional standing, such as hospital privileges, active license. The second is lifelong learning and self-assessment through participation in continuing medical education activities. And the American Board of Pathology actually has some of these CMEs converted into what we call SAMs, or self-assessment modules that actually then recall what the learner has learned from the continuing medical education activity, and they have to answer questions and get a certain percentage correct. So it's a type of CME, and 70 of those are required during a cycle, of which 20 must be SAMs. The third is probably the most anxiety-generating for our trainees and practitioners, and that's the assessment of knowledge, judgment, and skills. Currently, this is done every 10 years at the time before the expiration of the time-limited certificate by taking a high-stake 10-year examination. And the fourth component of the maintenance of certification program is improvement in medical practice, where the candidate has to demonstrate continuing professional competency and quality assurance activities. And this actually is a pretty easy regulation for most of ours to meet, because there's a lot of QA that we do every single day, so it's not hard to show this. And diplomats must report Part 1, 2, and 4 to the American Board of Pathology every 2 years, and the exam is once in 10 years currently. So in summary, the American Board of Pathology works collaboratively and very closely with training and accreditation organizations. We have our trustees and CEO as members of the board and on these review committees. So we have significant input into the training and education. We also work very closely with several of our pathology professional organizations that are officially cooperating societies and provide input, as well as provide the CME and SAMs for our diplomats. So our ultimate aim is to promote lifelong learning as well as continuing certification of all our diplomats. So I'd like to share with you some recent initiatives that the ABP has been involved with respect to residency training and maintenance of certification that I think may be of interest to this group. So I mentioned earlier the Workforce Summit that was held by Pathology as a collaborative get-together in 2013. And the survey that was developed from this was done essentially to determine how pathology residency training and initial certification align with the knowledge and skills needed for pathology practice in academic as well as community settings. And we did administered the survey in concert with the maintenance of certification reporting, so it was limited to pathologists who were 10 years or less in practice. The desired outcome of this training practice survey, which has been deployed for 4 years in a row now, was we wanted to determine what does every pathologist need to know versus what do some or few pathologists need to know when they're in practice. We also want to assure that every pathologist has essential core training to do the job that they need to do, and determine how to adjust the amount of training so that we can train diplomats and trainees for the future practice of pathology. Perhaps one way of doing this is to move more specialized training into fellowships, and also identify key emerging areas that actually should be part of core pathology training that are currently not so. So our 2016 results were similar to prior surveys. Most practicing pathologists felt that the residency training that they got was just about right in most areas. And we surveyed for about 42 practice areas. So as you know, pathology laboratory medicine is a vast area when you include anatomic and clinical pathology. There were 5 areas that stood out that the training was perceived not to be quite right. And this suggests to us that there's a need for realigning training in these areas. Not surprisingly, molecular diagnostics and pathology informatics reign high in this list, and also laboratory administration, coding, billing, and a new one this year was dermatopathology. show you some of the data that we gathered from this survey. So here you can see in blue academic practice pathologists and non-academic hospitals. And on the x-axis is the importance that these people gave the practice areas. And as would be expected, it's not surprising that for academic pathologists, there were many areas that were not so important that they got trained in. Whereas for the community pathologists who practices general pathology, even though they may be subspecialized in one or more subspecialty areas, they felt that there was importance that was given to many more practice areas, just simply reflecting the generalized nature of their practice. If we break that down into surgical pathology and the sub areas or under the surgical pathology setting, again, we see that in red, the community pathologists versus the academic pathologists in blue found that they utilized training in all of these much more across the board, whereas in academics, a lot of these areas were not as important as they were because, again, they are more specialized in one or more areas of surgical pathology. If we looked outside surgical pathology into other areas of anatomic pathology, such as cytopathology and laboratory medicine, hematopathology, we again see that in red, the community pathologists found training to be useful and important across most of these. Interestingly, pathology informatics was rated similarly by both academic and community pathologists. Clinical consultation got a very high importance from both of them, rightly so. And then areas, again, such as grant writing and laboratory techniques, et cetera, were more important to academic pathologists. So our next step with these surveys is to try to define what the core training should be that every pathologist needs to practice competently, and where exactly is it needed, and when, in residency or in fellowship. What do we take away? We can't simply keep adding more to the plate that the residents and fellows already have. So how do we make these adjustments? Do we move more specialty training to the fellowships? We want to continue these surveys. We also want to map them to employers' needs and then come down on a better sense of being advised on how our specialty should proceed as far as training is concerned in the balance between residency and fellowship and the practice areas that need to be decreased versus increased or added. The second thing I want to touch upon is the resurgence of competency-based medical education. This is not a new concept at all, but has received increasing importance both in the undergraduate medical training arena as well as in residency and fellowship. What CBME does is it reconceives medical training by recognizing that not all students or trainees master all skills at the same place, i.e., learners learn differently and at different rates. So this kind of innovative model could create a learner-centric education system that in turn helps bring about a more patient-centric care system. This is a commentary that came out in the New England Journal very recently and is well worth a read. Hand in hand with this concept of CBME is entrustable professional activities. And I mentioned EPAs briefly earlier. What EPAs are their observable, measurable units of work, such as an autopsy in pathology or taking a good HMP and physical. And they require the integration of many competencies. So right now we're judging people on individual competencies, but what EPA suggests is that we may be better off doing it in judging these through EPA that requires integration of several of these that correlates better with the actual work that we do. So in this arena, Pediatrics is the poster child, and they already have programs in place where they're looking at this model from medical school through residency and fellowship and see how that training does and compare it to the more conventional training. There's lots of publications about how EPAs are being utilized in medical school training. And in pathology, we've just started discussing this, and we have a publication out by the College of Americans GME committee suggesting some EPAs that might be worth looking at too for pathology training. Autopsy is one, frozen section is another, and then clinical pathology such as interpreting an anchor test or a coagulation test, etc., would be examples. And the American Board of Pathology is committed to exploring the EPAs and working with our organizations to see how these pilots might work out and how they might affect training and in the future possibly certification of individuals who may be trained in this type of format. The American Board of Pathology also believes in self-regulation and continuous certification. We've issued statements in support of MOC with our cooperating societies and CMSS. We've taken a lot of initiatives over the years since we went to a time-limited certificate to make this process easier for our diplomats. Particularly, as I mentioned, Part 3, the exam, we've tried to make this less burdensome and much more appropriate to learning rather than just testing. We now have an option of remote secure testing, so you can take the test anywhere. You don't have to come to the office in Tampa or anywhere. You can take it at home or in your office, and we've been approved for that by ABMS after our pilot. We have comprehensive study guides so that the candidates know what they're going to be tested on, and we offer an amazing number of modules, 95 to be precise, so that our diplomats are able to personalize what they're going to be tested on based on their personal practice. And we've made major changes to the item bank so that our questions are much more relevant, more practical, and less of recall. We made some changes in Part 2 activities where it was quite cumbersome for the diplomats to collect all their CME, SAMs, and report them manually to the ABP. We now have invested in automated reporting of diplomats' CME and self-assessment modules, as well as for Part 4 activities through the ACCME system. And we've been taking a lot of stakeholder input into account as we look into improving our maintenance of certification program. And we have a very active MOC advisory committee composed of our diplomats that advise us and look at some of the initiatives we have planned and give us input into those. One of the most exciting things that we embarked on over the last year or so is to be one of 7 pilot boards that are involved in the ABMS's new CertLink platform. And this platform is a web-based platform that provides longitudinal assessment that's both formative as well as summative. And these pilots are due to last 3 to 5 years. They have voluntary participation by the diplomat. The diplomat gets 20 questions per quarter. They can use any resource they like to answer the question, and they get 1 chance as the correct answer. We've already been through our soft launch, and this summer we're going for our beta. And again, the diplomats are heavily involved in the creation of this platform, and we have crowdsourcing for the questions. So the hope of ABMS and the partner boards is that ultimately, if this is a successful system, it will become more of an assessment of learning or move from assessment of learning to an assessment for learning that becomes valuable and pertinent to the diplomat that is taking it. So I'll just show you a few snapshots from this. This is what the question or the challenge would look like. It would have a practical history with a question and possible answers. And the assessment would be focused on practice-relevant content because the diplomat can choose the areas that they want to be tested in. After they answer the question, the diplomat has 3 additional questions to help give us feedback. How confident were they in their response? How relevant the question was to their practice, and how relevant was the question to their specialty? And we analyze all of this at the back end. The diplomat, in turn, gets immediate focused feedback. They get a key point that was meant to be addressed with that question, key learning point. They get a critique that addresses the answer, why the correct answer was correct, and why the other choices were not appropriate answers for this particular question. And then there are references available for further reading. There's also additional data that the diplomat gets. There's a personal dashboard that displays their scores in comparison to their peers. It also highlights for them their areas of strengths and weaknesses that tend to stand out after you've taken a good number of challenges. And all of that is available in their personal dashboard for their learning. There's also guidance to resources for study before and after the assessment, both within the system to prepare for the exam, and then afterwards to look at challenges you may have got wrong and improve and read further on those. Retesting of key content is an important means of improving learning, and this system will do that. It will send questions on the same key concepts later on in subsequent quarters so that we can emphasize and improve the potential for learning. Recently, the ABMS issued the members of their committee as part of the vision for the future, which is phase 2 of their improvement effort towards continuing certification so as to establish a more meaningful, relevant, and valuable system. So we're here now in phase 2, which is the vision for the future. And they just rolled this out in a press release, who the members are. And what they hope is that they'll provide them input into this so that the program can improve in the interest of patient care. So my takeaway messages are there's a renewed focus on competency-based medical education, and longitudinal assessment is changing training and how we assess competence in our diplomats. Continuous certification should be relevant and of value to the diplomat. So it should be an assessment of learning and for learning. And the ABP is committed to proactively evolving to promote the practice of pathology and the continuing competency of practicing pathologists. Thank you.